Educating patients, families, and communities is at the heart of what we do as nurses. In the acute care setting, that's hospitals, it begins the moment we come into contact with patients. From unit routines all the way through discharge instructions, we are constantly educating. I think it's probably the most important aspect of what we do as nurses. Educating patients helps them understand their disease process, medications, labs, procedures, and so much more, but it also creates trust and respect for nurses as professionals. Welcome to the Nursing School Simplified podcast. I'm your host and lead instructor, Cynthia Primavera. If you're looking for inspiration and encouragement, help with studying, passing your exams, and surviving nursing school, you've come to the right place. My goal is to help you reduce your stress and make learning complex concepts easy and fun. Join me here every week where I cover all things nursing school related. I'm so glad you're here, so let's get started. Well, hey there, future nurses. Welcome back to another episode of the Nursing School Simplified podcast. I am so happy you're here today. I've been looking at the podcast downloads, and there are downloads from all over the world. I'm talking UAE, New Zealand, the Philippines, Ireland, Belgium, and Italy. But Italy doesn't count because that's my ex-husband, so remind me to tell you about him someday. It's a pretty interesting adventure. So I wanted to take a moment to remind you to subscribe to the podcast so that you don't miss an episode and you don't miss the bonus episodes, which I'm putting out a bonus episode this week. I'd also really appreciate it if you could leave a review and a rating, as it helps us reach more nursing students. So my goal is to try to keep this podcast fun, fresh, interesting, educational, and provide meaningful content. I thought it would be fun to do a monthly patient education series where every month I provide patient teaching for a specific disease process. So this month I decided to do it on diabetes. Now, make sure that you stay tuned until the end of the podcast because I have a cheat sheet that I've created and I want to let you know how to get it. So let's jump in and get started. According to the CDC, there are 34.2 million people in the United States that have diabetes. There are 26.9 million people that are diagnosed, but there are another 7.3 million who are undiagnosed. Now think about how scary that is. What's even worse is that there are an estimated 88 million people age 18 and above that have prediabetes, and that's about 34.5% of the adult U.S. population. And of that, 24.2 million are people over the age of 65. So prediabetes is where you meet certain criteria, but you are not yet at the level of where they start treating you and calling you diabetes. Maybe you have metabolic syndrome and your A1C isn't elevated high enough yet to be considered diabetes, but they're still walking around with quote unquote prediabetes. And just a pet peeve of mine is that I wish we would stop calling it prediabetes and just call it what it is. Diabetes. If we diagnosed sooner in these cases and were more aggressive with the care and education that we provided, we may be able to stop the progression of the disease process, reverse some of the damage that's been done, and create a healthier population. Let me give you another analogy. It would be like, it's like when they call a TIA, a transient ischemic attack, a mini stroke or a little stroke. A stroke is a stroke is a stroke, okay? Doesn't matter if it's a little stroke and you just have little to no damage, or residual effects, or if you have a huge monstrous stroke and you end up paralyzed, trached, and with a peg. A stroke is a stroke is a stroke, just like diabetes is diabetes is diabetes. Now, one thing I wanted to let you know is that back in the day, we used two different terms and acronyms to describe diabetes in adults, and it's really not used that often anymore. You might find it in, smaller facilities or in a physician's office where the physician may be old school and they're still referring to it in this manner. So the first one is called non-insulin dependent diabetes. NIDDM is the acronym. And the second one is adult onset diabetes, and that is AODM. So like I said, these are old. They're really not used. You might see them in some old documentation if you're going through charts. So just be aware of what those are. So there are two main risk factors for diabetes, and one is family history, and the second is overweight or being obese. One is modifiable and the other is not. So if it runs in your family, say thank you to your genes. There are 4 metabolic abnormalities that take place in diabetic patients. And the first one is insulin resistance. And that's where the body tissues don't respond to the insulin because the receptors are unresponsive, insufficient, or both. And that results in hyperglycemia. The second one is the decreased ability of the pancreas to produce insulin at the B cells site because they tire due to overproduction of insulin, or the B cell mass, meaning the size, is lost. The third abnormality is inappropriate glucose production by the liver. The fourth is the production of hormones and cytokines by adipose tissue. Now, research is showing that adipose hormones play a huge role in fat and glucose metabolism, and they're probably contributing to diabetes. So before we move on to signs and symptoms, I want to talk to you a little bit about metabolic syndrome. And metabolic syndrome is a collection of risk factors that increase cardiovascular disease and diabetes risk. And it's all related to insulin resistance and excess visceral fat. So the populations that are most affected by metabolic syndrome, are African Americans, Hispanics, Native Americans, and Asians. They're at the highest risk. And metabolic syndrome includes 3 or more of the following factors. The first one is obesity. The second one is hypertension. The third one is abnormal lipid levels. And the fourth one is elevated glucose levels. Again, with metabolic syndrome, we really need to start early education, early intervention, and initiate lots of mechanisms for the patients to be able to control this process. We need to let them know about diet and exercise and food choices. We really need to get aggressive with this if we don't want it to progress to full-blown diabetes or the patient developing cardiovascular disease. So let's talk about the signs and symptoms of hyperglycemia. We have elevated blood glucose levels, polyuria, which means excessive urination, polydipsia, excessive thirst, and polyphagia, which is excessive hunger. Patients may also experience weakness, blurred vision, nausea, vomiting, abdominal cramps, and this can progress to DKA or HHS very quickly. So there are 3 acute complications that you need to be aware of in diabetic patients. The first one is DKA, diabetic ketoacidosis. The second one is hypoglycemia. And the third one is HHS, hyperosmolar hyperglycemic syndrome. So let's talk about the first one, DKA. There are several signs and symptoms of acute complication, and that includes polydipsia, polyuria, dehydration, tachycardia, orthostatic hypotension, Kussmaul's respirations. Patients may have a fruity breath. Glucose levels are typically greater than 250 milligrams per deciliter. The pH is usually 7.3 or less. Our bicarb level is about 16 milliequivalents per liter or lower, and there are detectable ketones in the urine. Now, DKA, basically put, is a state of dehydration. Your DKA patients are going to be very, very dehydrated because of the fluid shifts, and especially if they're nauseated and they're vomiting and the polyuria. So we're losing lots and lots of fluid. So you must remember that they will be hemoconcentrated, meaning the blood is going to be very concentrated because of the dehydration. Our second acute complication is hypoglycemia, and that's blood sugar less than 70. Patients will be cold and clammy. They may be tachycardic. They might have mental changes, meaning like they could be nervous, agitated. They could be having tremors, like shaking. They can faint or be dizzy, unsteady gait, slurred speech. They could be very hungry, changes in vision, and if untreated, they can have seizures and go into a coma. So especially with our geriatric patients, they're not always going to exhibit the classic signs and symptoms of hypoglycemia, especially if they are long-term diabetics. What you will typically see, or you may see in our older diabetic patients, is that they are exhibiting signs and symptoms of a stroke. And that's usually one of the first signs that they're hypoglycemic. So always when you have your older patient, if you see a little droopy face or some slurred speech or a little bit of a mental change and perhaps maybe an unsteady gait or unsteady movements, uncoordinated movements, I want you to remember this, and I want you to think in the back of your mind, could this be hypoglycemia? Our third acute complication is HHS, and this is hyperosmolar hyperglycemic syndrome. And this can be life-threatening. Typically, glucose levels are over 600. We have increased serum osmolality, so our patient is dehydrated. One key factor, and remember this for a test, ketones will be absent. It's common in patients with diabetes who are over 60, and it does have neurologic complications. Now, chronic complications of diabetes include macrovascular and microvascular complications. Macro means large, so large vessels, are neuropathy, nephropathy, and retinopathy. So we have peripheral nerve damage, we have renal nerve damage, and we have retinal or eye damage. Our microvascular complications are cardiovascular, peripheral, and cerebral vascular. So you can see how diabetes, because of neuropathy, because of the microvascular complications, patients are at risk for blindness, kidney disease, cardiovascular disease, cerebrovascular disease, and peripheral vascular disease. Here's something, it's not funny, but I think it's funny now when I think about it. Back in the day before I was a nurse, I was out to breakfast with my family, and I remember seeing a gentleman go up to the counter to pay for breakfast. And he was wearing shorts, and I was looking at him, and I thought, my gosh, what a funny tan that man has. Because from a little bit below his knee, his shin or his knee, it was completely discolored. And I mean, it looked tan and compared to the rest of his skin. And I thought, what an odd tan. Like, what must he have been wearing to just tan that portion? Like, those must have been some long shorts. But now that I'm a nurse, and when I was in nursing school, I learned that this is vascular disease. This is peripheral vascular disease. And once you see it, you will never forget it. So in your patients that have peripheral vascular disease and diabetes, we are at risk for heart attacks and strokes and blindness. So that's why it's so important to get on top of diabetes when it's first diagnosed or pre-diabetes. And that's why it's important to educate our patients so that they can have some control and hopefully modify their lifestyle, modify their food choices, stay with their medication regimen until they can get to the point where it's very well controlled or it's completely reversed, because it is possible when it's diagnosed early enough to reverse diabetes. It is very possible. Now, my mom was diagnosed, I want to say about 10 years ago with diabetes, and she was adamant that she did not want to have dialysis. She likes getting her toes painted, so she didn't want to have, any amputations going on down there. And she got right on top of her diabetes, checking her sugar when she got up, before her meals, adjusting her diet accordingly. She started exercising, and this was when she was in her 60s. And she controlled her blood sugar so much and so well that after about 5 or 6 years, her physician told her that he no longer considered her diabetic because all her numbers had come down and her A1C had been below 4. So it is possible, but you have to catch it early enough, and you have to give your patients support, you have to give the family support, and you have to give them lots and lots of education. So for educating our patients, we want to talk about health promotion. And there are 2 factors to educating our patients, and the first one is health promotion. So we want to educate them about the disease process. We want to make sure that they're aware of complications. We want them to know signs and symptoms of hyperglycemia, hypoglycemia, and DKA especially. The HHS, it's a little complicated, but you can educate them about that. But as long as they know that if their blood sugar is over 250 and they're experiencing those signs and symptoms, when they get to the hospital, we can leave that up to medical professionals to differentiate between the two. It's a lot of information for them to take in, and so we want to make this as simple as possible. We also want to make sure that, especially for our new diabetic patients, that they know how to monitor their blood sugar, how to use the AccuCheck machine correctly, and what those numbers mean. We want them to have a medic alert ID on them in the event that they become hypoglycemic and they pass out, or even with hyperglycemia, they get so altered that they're unable to communicate. If they have the medic alert ID, that can communicate for them. We want to make sure that they understand their medication regimen. So whether it's PO diabetic medications like metformin, or they're taking insulin, we want them to understand how these medications work, when they should be taking them, what are the side effects, what to do if they take too much. We also want to make sure that they understand that they should have tight control of their blood sugar, meaning we want them to keep it between a certain level that's specified by the physician. They also should be following up frequently with their physician. And usually the doctor wants to see them every year, but they should be going at least every 6 months just to get updates on labs, make sure that they're not experiencing any other signs or symptoms that maybe they've forgotten or are unaware of. They also need to get their vision checked regularly because remember, we talked about macrovascular complications, and one of those is retinopathy. So we want to preserve their eyes. We want to preserve their vision. We want to make sure that they understand that they should be eating a low-calorie diet. And on another episode, I will talk to you about the ADA and new findings on diet and carbohydrates, and especially for diabetics. We also want them to discuss with their pharmacist, the MD, about over-the-counter medications and herbal medications. And this should be all patients because we just don't know, there's so many herbal remedies out there, vitamins, and with whatever medications they're on, it's just impossible to know all the interactions. And so they should be consulting their physician or a pharmacist when they're purchasing these over-the-counter or herbal remedies at the drugstores, because it could change the way the medications work. And we don't want that to happen because it could either potentiate, make those medications stronger, or it can make them not work at all, making them inert. So we want to make sure that they understand this. We also want them to know that they should be adjusting their medications, adjusting their PO intake on days that they're sick and when they're exercising. One of the most common times for patients to come in DKA is when they're sick. And so we want them to be aware of that. And for the love of all, we want them to stop smoking. I'm going to repeat that again. They need to absolutely stop smoking. And why? Because smoking is bad, first of all, but smoking causes vascular damage. So now we have diabetes, which causes macro and microvascular damage. And then we're going to put smoking on top of that. And now they're adding to that vascular damage. And no, vaping is not better. No, it is not better. So we want them to stop completely. If they need to get the patch, if they need to go through like a little smoker's 12-step program, whatever they need to do, they need to quit smoking. So the second aspect of diabetic teaching that is just as important, actually, it's just as important. I think it's more important in some aspects because it can have greater complications. And by the time patients reach this point, they are already suffering from multiple complications from this disease, and it's just going to get worse. So we want to make sure that we educate family and patient on proper foot care. Foot care is the most important thing for diabetics, whether they're newly diagnosed diabetics or they're chronic diabetics. And the reason is because as the diabetes progresses and they develop neuropathy, right? Peripheral nerve damage. They lose sensation. They don't know, when they've bumped their foot or cut their foot because they can't feel it. They might have like numbness and tingling, or they might have that pins and needles sensation, but otherwise they're not feeling when they have a sore. Let's say you wear a shoe that's too tight and you get a blister. They may not feel that. And because they have vascular damage, we have delayed tissue repair, right? Our patients have decreased tissue integrity. And a lot of times in these patients, especially if they have hypertension, we are going to have tissue integrity issues. And so it's very important to get on top of that. So foot care. And I don't like feet. I have an aversion to feet and eyes. Those are my two things that I just can't. So we want them to inspect their feet daily. In the morning when they get up, they're to look at their feet. They need to look at the bottom of their feet. They need to look in between their toes, make sure there's no sores or cracked skin. They need to wear shoes at all times. And they need to switch their shoes at least every 2 days so that we don't develop rub patterns on the feet. They should also be wearing cotton socks because those are breathable and the fabric is safe for the skin. And let me go back to that, wear shoes at all times, because they need to even be wearing shoes in the house. So they can be wearing, their cotton socks and their shoes. They cannot be going around barefoot or just in socks in the house. They should not be wearing open-toed shoes or sandals with straps that go between the toes or around the back of the heel. They should be washing their feet with warm soapy water and checking the temperature before they do get in the shower or the bathtub, because if they have advanced neuropathy, they may not feel if it's too hot. They are not to soak their feet at all. We want to make sure that they completely dry their feet, especially between the toes. We don't want moisture building up in there and causing, like athlete's foot or fungus or cracking or irritation. We want to make sure between every one of those little piggies, okay? We want to make sure that they moisturize their feet, but again, not between the toes. No heating pads or ice packs on their feet at all. They need to cut their toenails straight across. Now, I tell my diabetic patients, my diabetic female patients who have cute, manicured toes, that perhaps they should not be going to the manicurist to get pedicures. And why? Because we don't know how well the equipment is cleaned and sanitized. And we don't want any potential infection getting in their feet, in their toes, because it'll be hard to fix, hard to cure. They're going to be on lots of antibiotics, and even then it may not fix it all, and they can develop other complications. And especially if the manicurist cuts their toenails wrong or cuts them in any way, like when they're scraping their feet, it can have potential ramifications, bad ramifications, and these patients can end up losing toes. So I always tell them, even though this is, something we all love to do, they probably shouldn't do it and just do home manicures, home pedicures. And lastly, they should be seeing a podiatrist at least once a year, but more often if they're experiencing complications with their feet, their toes, their nails, because the podiatrist will get right on top of it and make sure that they have the proper care, proper wound care, and that it doesn't progress to something worse. Now, I have been thinking, I work with a very good podiatrist. And so I was thinking about having him on and talking about diabetic foot care, because he has actually done so much at our facility to really revolutionize the care that we're providing these patients. And so I thought it might be something fun and interesting. So I'll keep you posted. So now that we've covered all that, I want to just back up a little bit and kind of go over teaching and how we should be teaching all this information, because it's a lot. It really is. And I understand how patients and family members can become so easily overwhelmed, especially when they don't have the knowledge that we do and they don't have the anatomy and the physiology understanding that we do. So it's always important to take these things into consideration when educating. And we shouldn't be educating in huge chunks of time where we're sitting down for, 30 minutes and educating. They should be short little pieces of time where we just provide enough information that they can consume it and digest it and ask appropriate questions. So when we are educating, we need to explain everything in a way that they understand, and we need to use as many tools as possible, whether we use printed materials, video, verbal teaching, however the patient indicates that they learn best. But it's always best to use some kind of combination. So I like to use, I verbally tell my patients, but I also give them printed material. And then in our hospital, we have a video system built into the TV with videos that they can watch as well. So they get that auditory visual combination, and they're able to digest that information and comprehend the information a lot easier. We also need to make sure that if our patients have a language barrier, that we are utilizing tools that are in their language. And also, especially for like new diagnosis of diabetes, it is always best, always to have a certified interpreter, whether you use the language line or you use someone in your facility, because there are terms and things that we want to make sure that they are being taught or spoken to properly. Because I know I speak some Spanish, and my Spanish is not correct. It's a little bit of dialect because my grandmother spoke Spanish. And so I don't always use the correct terminology, and it's always important to use the correct terminology with them. We also want to be aware that every time we enter the room, we're educating, right? From the minute we come into contact, we are educating. We're telling them about unit routine. We're telling them about when their meals are coming, about labs or diagnostics, or our assessment. We're teaching them about everything. So I think it's important, especially when we're talking about disease process or medications, we need to make them aware that we're educating them and saying things like, Mr. Smith, let me teach you about this medication. Or, Mr. Smith, let me teach you about your disease, about diabetes. Mr. Smith, let me show you how this is done. I'm going to teach you how this is done. They should be hearing that word teach, because it triggers that, hey, I'm being taught something. Also, with the way insurance is now, especially government insurance, hospitals are required to prove that we've educated these patients. And one way to do that is they send surveys to the patients after their discharge, and they specifically ask, were you educated? Were you taught? And if the patient says some of the time or none of the time, the hospital does not get reimbursed for that particular patient's care or a portion of the care. They reduce the percentage of reimbursement. And so it behooves us to document what we educate our patients on. A lot of hospital systems, they're doing computer charting, and so that's super easy. Even with paper charting, it's pretty easy because they have boxes most of the time, but you want to make sure that you hit those key educational components, because if the patient is readmitted within 30 days with the same diagnosis, the hospital does not get reimbursed for the care for this second for the second admission. So it's very important that we educate thoroughly and that we document thoroughly. We also want to make sure that patients and families are able to verbalize their understanding. So we want to ask open-ended questions. Things like, Mr. Smith, did you understand what I just explained to you? That's not open-ended, because Mr. Smith can just go, and we walk away thinking we've done our job, when really Mr. Smith is just too embarrassed to admit that he didn't understand it all. And that's very common, which I always tell my patients, listen, if there's one thing you don't understand, one word, one concept, one anything, please let me know. I know that you don't know this stuff. I know that you didn't study anatomy. I know that you didn't study physiology and pathophysiology and chemistry. So please, 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 if you don't know what I'm saying, if you don't understand what I'm saying, please, please tell me so that I can put it in a way that you do understand. But you should be asking things like, Mr. Smith, tell me what you understand about diabetes. Mr. Smith, can you explain to me how this medication works? Mr. Smith, can you show me how you'll be checking your blood sugar? Mr. Smith, can you tell me how many times a day you will be checking your blood sugar and when? Things like that where they're prompted, because then we really know. That's when we really know whether what we've taught has actually stuck inside their minds. We also want to remember that a nod does not mean that they understand. It's a human thing that we just nod our head and we're going, mm-hmm, mm-hmm, mm-hmm. And, sometimes I do it and I'm just trying to get people to move along, mm-hmm, mm-hmm. And we don't know why they're nodding. And culturally, some cultures will just nod because they're nodding in approval. And again, it goes back to people just don't want you to know that they don't know because they feel like they should and they shouldn't. And we also want to remember that non-compliance is not always patients' refusal to follow the healthcare plan. And we have to start asking our patients, why? Why aren't you checking your blood sugar? Why aren't you taking your medication? And sometimes it's, economic issues. Sometimes it's too much to take in what they're dealing with. A lot of diabetic patients, and actually a lot of patients with chronic disease processes, have a little bit of depression about it. And I really feel like we're not addressing that enough and giving patients enough knowledge and power to have control over, or some control over what's happening to them, because they feel like what's happening in their bodies out of their control when it's really not. And they may not be able to control it completely, but they can control it somewhat to the point that we reduce further damage. And so it's important to try to get to the point of why aren't you taking your medication? Are you having trouble getting your medication? Sometimes they can't get to the pharmacist, but now we have pharmacy delivery services. And so there are ways to make it easier. And in those instances, that's when we do collaborative care and we get our physician involved, we get our social services involved, we get our case managers involved, and we get those things set up for them so that they can get their medication, because we do want to keep them out of the hospital and we do want to keep them healthy. And lastly, the most important thing, it's up there. Don't forget to document. Because remember, if you don't document it, it didn't happen. So that's it, future nurses. I hope this really helps you understand diabetes, DKA, hypoglycemia, HHS, acute complications, chronic complications, and patient teaching. I have created a free cheat sheet for you that has all this information for you to use as a resource and a study tool. And so when you go to clinical and you start educating your patient, your instructor is going to be so impressed and you're going to do really well on your test. All right. So you go to NursingSchoolSimplified.com/diabetes and I will send that to you right away. Don't forget to like and share us on Facebook at the Nursing School Simplified page. And if you want to get into our group, we have a great group. It's growing so fast. And I'm doing lots of extra teaching inside the group. And I would love to have you there. And I'm doing some different cheat sheets specifically for the group. So there's going to be lots of things in there that aren't on the podcast and aren't on the main page. So when you go to the main page on Facebook, just click Join Group. There are 3 little questions that I ask you to respond to. One is, are you going to follow the rules? 2 is, what subject are you having the challenge with? And I think the third one is, what semester are you in? So they're real easy. There's no pass or fail, but it helps me understand where I need to direct the content. And I'm working on putting in more units so that you have more information that you can access. And so, like I said, that's only exclusive to the group. So you won't be seeing that anywhere else. I might do podcasts on it, but it would be later down the road, or it won't be the full information on the podcast. So go ahead and make sure you join that as well. So I hope to see you there. I want to leave you with this final thought. Believe in yourself and you will be unstoppable. Until next time, have a great week and keep working on your dreams.